Subcommittee will come to order, and good afternoon. During the last several years, conflicts in the Middle East have cost the lives of hundreds of thousands of people. It's estimated that as many as 470,000 people have been killed either directly or indirectly due to the fighting in Syria since 2011. During that same period, more than 30,000 people have died in Iraq. In Yemen, more than 5,000 have died in a series of conflicts since 2009. As a result of the conflicts in these countries, as well as the influx of refugees from conflict zones into surrounding countries such as Turkey, Jordan, and Lebanon, many of those who die are the victims of disease. Almost 17 million people in the region are in need of humanitarian assistance, including roughly 4 million refugees who have fled their countries and additional 13 million IDPs. Dr. Peter Hotez, one of our distinguished witnesses today, points out that, and I quote, "We have already seen polio and measles reemerge, and we are now seeing a massive surge, more than 100,000 cases, of highly disfiguring parasitic disease known as leishmaniasis, which the locals call Aleppo evil. It is transmitted by sandflies that thrive in the uncollected garbage of Aleppo and other urban areas of Syria, Iraq, and Libya. The disease causes horrific ulcers that can appear in the face and very seriously disfigure people, especially girls and women," he goes on to say, "leaving them with permanent scars that render them unmarriageable. There is a medicine that is administered by injection of an antony containing a compound onto the lesion, but there is an access problem in the affected areas, and the bottom line is that we need a vaccine," close quote. Today's hearing will examine the scope of the cholera and other diseases to determine what can and should be done to control those diseases, assist those who have been afflicted, and mitigate their spread. The World Health Organization reported that the spread of the cholera epidemic that first began in Iraq in 2007, that crossed over into Iran, Syria, and is considered the region's greatest, although not only health threat. These threats are worsened by the targeting of healthcare workers in Syria and an Islamic State that has no experience and little interest in providing social services. Thus, cholera and other diseases are untreated, often unreported, and pose a significant health threat in the region due to poor sanitation and overcrowding in areas such as refugee camps. Cholera is an acute diarrheal disease that can cause death within hours if left untreated. Roughly 80% of those who contract the disease do not develop symptoms, leaving some uncertainty about precisely how many people contract the disease annually. Scientists estimate that between 1.4 and 4.3 million people contract it annually. Cholera bacteria are present in the feces of infected people for 1 to 10 days after infection and can be spread to others if they ingest food or water that is contaminated with their fecal matter. The spread of cholera is mostly facilitated by inadequate water and sanitation management, and outbreaks are common in areas where basic infrastructure is unavailable, such as urban slums and camps for IDPs and for refugees. As devastating as this cholera epidemic has been and can be going forward, we must also remember MERS epidemic of 3 years ago. The Middle East respiratory syndrome is a respiratory illness. It is caused the virus was first reported in 2012 in Saudi Arabia. It is different from other viruses that have been found in people before. MERS, like other viruses, is thought to be spread from an infected person's respiratory secretions, such as through coughing. However, the precise way the virus spreads are not currently well understood. The conflicts and political crises in the Middle East have brought anguish, suffering, and severe declines in health to people throughout the region. The most catastrophic case is by far Syria. More than 1 million people have experienced traumatic injuries. Once rare infectious diseases have returned. Chronic diseases go untreated, and the health system has collapsed. In Yemen, Libya, Gaza, and Iraq as well, violence has limited access to health care and grievously harmed the population. According to Physicians for Human Rights, last summer, at least 633 medical personnel had been killed, and more than 270 illegal attacks on 202 separate medical facilities had taken place since March of 2011 in Syria. Of the attacks on medical facilities, at least 51, or 19%, were carried out with barrel bombs. Almost all of the assaults were inflicted by the regime of Assad. In the Middle East, threats against, as well as arrests and intimidation of health workers, extends beyond armed conflict to situations of political volatility, as is evident in Bahrain, Egypt, and Turkey. In most of these cases, doctors and nurses who treat victims of violence are, by the very act of providing treatment, deemed guilty of anti-government activities. In Bahrain, almost 100 doctors and nurses were arrested and 48 originally charged with felonies for having offered medical care to wounded people in the wake of the 2011 Arab Spring uprising. Our panel today is comprised of health experts who will help us think through the health challenges, provide a roadmap with good concrete data and empirical information for us to consider as a subcommittee, which I can assure you will be used in helping us advocate for more assistance and more help to those who have been malafflicted. I'd like to yield to Dr. Burr for any opening comments.
Thank you, Chairman Smith, and thank you to the witnesses for taking time to be here today. You know, as I think about, as a physician and someone who's done public health and global health work, you think about the conditions in the Middle East as they are today in terms of diminishing infrastructure, refugees that are in crowded conditions, diminished sanitation, malnourished populations, and the environment is ripe for, whether it's outbreaks of cholera, but also other infectious diseases. So I'm very interested in getting a sense from our panel today, what measures we can take in terms of, trying to alleviate and prevent some of these issues. Obviously, vaccinations as appropriate, but even in a war zone, that's very difficult because, as Chairman Smith has already indicated, to try to get healthcare workers in there, to try to get folks in there to help assess sanitation conditions, apply vaccinations where appropriate, and deliver rehydration salts or other therapies for those that are affected is very difficult to get that care in. I'd be curious from experience in other war zones and other conflict areas, the things we can do to try to, while we may not be able to prevent some of these outbreaks, what we can do to mitigate and minimize some of these outbreaks, knowing that we may be stuck in a conflict zone, not for months, but maybe for a prolonged period. And that, if we just look at Syria itself, much of the healthcare infrastructure is being devastated and will take quite some time to rebuild. So, again, I will keep my opening statement short and save time for questions, but look forward to hearing from the panel. Thank you.
Thank you, Dr. Burrow. I'd like to now welcome our distinguished panelists, and without objection, your full statements will be made a part of the record, but please proceed however you like. And your full resumes will be made a part of the record. Beginning first with Dr. Peter Hotez, who is president of the Sabin Vaccine Institute and leads the Texas Children's Hospital Center for Vaccine Development based at the Baylor College of Medicine. He is also founding dean of the National School of Tropical Medicine at Baylor. His academic research focuses on vaccine development for a wide range of neglected tropical diseases around the globe, as well as studies to increase awareness about the neglected tropical diseases in developing countries and in the United States. Dr. Hotez created the Sabin Vaccine Institute Product Development Partnership and was instrumental in creating the global network for neglected tropical diseases. In 2014, he was named by President Obama as one of 4 U.S. science envoys with a mandate to explore the development of vaccine centers of excellence in North Africa and the Middle East. I would note as well that our End Neglected Tropical Diseases Act, having had Dr. Hotez appear before this subcommittee on 2 previous occasions, has passed out of the Foreign Affairs Committee, and we greatly benefited from the insights, Dr. Hotez, that you provided as to what that legislation ought to look like, so thank you. We'll then hear from Dr. Istam Rad, or Rad, how do I say that? Rad, who is an infectious disease specialist who is a distinguished professor of medicine at the University of Texas at Houston. He is president of Health Outreach to the Middle East, or HOME, which is a Christian interdenominational organization that exists to bring physical, psychological, and spiritual healing to poor and suffering people in the Middle East in the name of Jesus Christ. Home has established a program to train, build, and send thousands of Arab Christian and physicians and healthcare professionals on how to share the love of God at the bedside. Home supports 3 medical clinics, 1 charity hospital, a home care medical service, and mobile clinic that provides medical care for the people of Egypt. Then we'll hear from Dr. Stephen Morrison, who is a senior vice president at the Center for Strategic and International Studies and director of the Global Health Policy Center. Dr. Morrison writes widely, has directed several high-level commissions, and is a frequent commentator on U.S. foreign policy, global health, Africa, and foreign assistance. He has served in the Clinton administration as committee staff in the House and taught for 12 years at Johns Hopkins School of Advanced International Studies. Dr. Hotez, the floor is yours.
Mr. Chairman, members of the subcommittee, Mr. Berra, thank you so much for giving me the opportunity to talk about a very ominous situation that's now happening in the Middle East, and now we're recognizing a spillover into Southern Europe. So this thing is already going beyond the Middle East and North African region. Before I do that, I just thought you might like to hear a little good news based on the work of this committee and subcommittee. I'm part of an enormous initiative known as the Global Burden of Disease Study that's funded by the Gates Foundation to evaluate what the impact has been of all these big picture programs like PEPFAR and the President's Malaria Initiative and the USAID NTD program. And this is involving hundreds of scientists all across the world to evaluate the paper. The papers that come out look like something out of the CERN physics laboratory, massive numbers of authors, and I'll be happy to share that with you. But I want to just give you the punchline of what's happened since the launch of all of these big programs. We've now seen a 30% reduction in the number of malaria cases and the number of malaria deaths. You guys did that, so congratulations. You turned the corner on HIV/AIDS, 19 million lives saved from HIV/AIDS, and for the first time, turning the corner in the number of deaths. And then for neglected tropical diseases, you've reduced the number of cases of lymphatic filariasis, which is also known as elephantiasis, river blindness, and blinding trachoma by almost 40%. So to the point now where we could talk about eliminating these 3 diseases over the next decade. To date, over 500 million people have received treatments for neglected tropical diseases, totaling more than I used to say 1 billion treatment. I just got corrected yesterday by somebody from USAID. It's now 1.4 billion people. So these are incredibly effective programs, and now you have an independent documentation to know how they're working. So congratulations, and thank you for your leadership on that. Well, let's get to the not-so-good news part of the story. The impact of all these big picture programs has also, like peeling away the layers of an onion, revealed a new problem. And that we've just completed a large-scale analysis in a series of papers to show that today most of the world's neglected diseases are now occurring in wealthy countries, in G20 countries. So we've been ignoring the poor who live in wealthy countries, and now accounting for at least half the world's worm infections, most of the dengue, most of the Chagas disease, most of the tuberculosis, most of the leishmaniasis, and quite a bit of the HIV/AIDS. The silver lining on that is, because these are inherently wealthy countries, with quotations, it's not just a resource problem, it's a political will issue. So that we need to think about providing advocacy at the next G20 summits about how to get these global leaders to pay more attention to their own vulnerable populations. So an example would be China. Eastern China is incredibly wealthy. You go into Western China, into Sichuan, Yunnan province, you go back in time 50 years. Or we look at Mexico, into southern Mexico, or northeastern Brazil, where the Zika epidemic is. The Zika epidemic in northeastern Brazil is occurring in the same place where the epicenter of all the other neglected tropical diseases are. These poor, small states of Pernambuco and others where you're getting lymphatic filariasis and schistosomiasis as well. So paying attention to these pockets of intense poverty in G20 countries is going to become an important new global health theme. Let's talk about the Middle East and North Africa. I like to say that the reason why Ebola emerged out of West Africa is not because it was tropical, even though it's a neglected tropical disease. It was because those three countries, Guinea, Liberia, Sierra Leone, had undergone a decade of atrocities, and with it, the collapse of its health system infrastructure. So we're now seeing the same thing happening in the ISIS-occupied areas of Syria, Iraq, Libya, and now to some extent Lebanon as well. And the problem is it's very difficult to actually work in these countries to observe firsthand. So we have to rely on glimpses that we're getting of refugees spilling across the border and into Turkey, Lebanon, Jordan, Egypt, and that's where we're starting to see it. So you've mentioned leishmaniasis, Aleppo evil. It's transmitted by sandflies. Even in the best of times, it was difficult for the Syrians to control this disease. And now, in the face of the collapse of the Syrian regime, what we're seeing is massive numbers of cases, more than 100,000 in the last year, people with horrific ulcers that disfigure the face, especially little girls who were then rendered unmarriageable later in life. There is a medicine that could be used to treat it. It requires an injection of the medicine in the lesion. Of course, the medicine's now unavailable, but also with all the garbage now piling up, the sandflies are having a field day where they're proliferating incredibly, so they're able to bite people and transmit the disease. The disease is following the sandflies are following the refugees into the border camps, and the disease is continuing there. And this is happening not only with leishmaniasis, although because it's so disfiguring, it's one of the more dramatic examples. We're seeing the emergence of dengue or other arboviruses, scabies, malaria, tuberculosis, schistosomiasis, hepatitis A and B, and as you mentioned, the resurgence of measles and polio. The other thing that's happening in this serious situation is not only humans are being trafficked, but animals are as well. So there's no border anymore. So with that, all of that trafficking of animals, we're seeing a lot of zoonotic diseases transmitted from animals to humans. So an enormous amount of brucellosis. We're quite worried now about Middle Eastern respiratory syndrome, MERS coronavirus, going beyond the Arabian Peninsula. This is going to be, we think, an important problem that can cause an epidemic. We have additional issues that come up as well, which is that another big area of human migrations is the annual Hajj, the pilgrimage. It's believed that dengue fever actually got introduced in the Middle East through the Hajj, and because they have the mosquitoes there, when dengue got introduced, it spread across the Arabian Peninsula in the Middle East. And I just came back from Saudi Arabia. We're having discussions with the Ministry of Health there that they're worried now about Zika coming into for the same reason. So there's every reason to believe that Zika is going to go in. These diseases are having a massive economic impact on the region. We've just completed an analysis looking at the neglected tropical diseases in the OIC countries, the Organization of Islamic Cooperation, and there's quite a bit of evidence that the OIC countries are disproportionately affected by NTDs, and this is one of the major barriers to their economic development. Now we're seeing spillover into Southern Europe. So something quite interesting is happening. For the first time in 70 years, malaria has reemerged in Greece. It had been eradicated, now it's back. We're seeing the appearance of dengue in Portugal after 50 years. We're seeing West Nile virus and chikungunya in Spain and Italy. We're seeing schistosomiasis, which is the ultimate neglected tropical disease of poverty, is now on the island of Corsica. There's transmission of schistosomiasis in Corsica. So we think that a lot of this is having to do with spillover from the Middle East. So we're now seeing the first evidence that it's not just being contained in the region. So let me end by just saying what I think we need to do about it. In my role as science envoy, it's clear that there's no capacity for making vaccines for any of these diseases in the Middle East and North Africa. They're still entirely dependent on the multinational pharmaceutical companies, Glaxo and Merck and Pfizer, for making these vaccines. The problem is these diseases, for now anyway, are regional importance, not global importance. And so the big pharmaceutical companies aren't going into this. And we saw this before with Ebola, right? The technology to make the Ebola vaccine was actually first published in 2003, but the technology sat there for a decade because the big pharmaceutical companies weren't interested in making an Ebola vaccine. It's because the business model is broken. It says an academic researcher develops it, then waits to license it to a big pharmaceutical company, turns it around to a vaccine. And of course, by the time Glaxo and Merck did this for Ebola, because BARDA put up $100 million at the 11th hour, 5 minutes to 12, they made the vaccine in record time, but by the time they did testing, Ebola was gone and 11,000 people perished. We still haven't fixed that problem. The same now is coming out of the diseases in the Middle East. So one of the things that we're trying to do, and this will be a key component of the Center of Excellence, is at the Sabin Vaccine Institute, which is based at Texas Children's and Baylor College of Medicine, we are making the vaccines that people won't make for these diseases in the Middle East. We're making a leishmaniasis vaccine, a schistosomiasis vaccine. And the nice thing about us, because we're nonprofit, we can teach others how to make vaccines. So we're teaching the Saudis now. We're working with the Tunisians, the Moroccans, to build their own capacity. You can't walk into Merck or Pfizer and say, teach me how to make a vaccine, but we can do that. And so this is an active program going on now. We have a group of Saudi scientists coming to our laboratory to learn every aspect of the vaccine development cycle. They'll bring it back to Saudi Arabia, and we hope that we can do this other times as well. And that's also important because we've, as you can imagine, relations with Saudi Arabia have been strained over the last year, so being able to offer something like this to promote joint vaccine development is a really great example of what I call vaccine diplomacy. So thank you so much for having me speak.
Dr. Hotez, thank you so very much for your leadership. Dr. Rad.
Thank you very much. Mr. Chairman, members of the subcommittee, Mr. Vera, and the Chief of Staff, Mr. Simpkins. It's a pleasure to be with you today. I would like to, again, emphasize what Dr. Hotez mentioned, that the devastation resulting from the conflict in the Middle East creates the right environment for these alarming epidemics that have spread rapidly within the region, and there is concern that it could be a global spread. This has been also associated with the devastation, if you may, and the collapse of the local healthcare system in the area. And as you mentioned, Mr. Chairman, cholera is reported in 2015 in Iraq is the tip of the iceberg, if you may. For example, the World Health Organization reports 5,000 confirmed cases between September to November 2015, with several deaths. But reports from our clinic in Baghdad, where we have clinics in Baghdad, we have in Kurdistan, we have even in the suburb of Damascus, we have in Lebanon, Jordan, and Egypt, and in North Africa. But the report from the clinics there that this is a vast underestimate. This is almost 2 to 5% of the cases actually contracted there, which we estimate in around 200,000 cases and 15 of the 18 governorates in that part. The concern also with cholera is that cholera is unique among waterborne bacterial infectious diseases and its potential for global pandemics. And now we're in the second and the third wave of the 7th pandemic with more antibiotic resistance and acquisition of newer, more intense cholera toxin associated with cholera. And also the concern is that some of these clusters or outbreaks occurred in Iraq in Najaf and Karbala, which are part of the holy shrines in that country, with all the influx with Shiite Muslims going to these religious pilgrimage areas. The other big concern is polio, and this has been mentioned, but polio was thought to be eradicated in Syria. But it emerged in 2014 with more than 7,600 cases, and the big concern is that it occurred, the epicenter for the outbreak started in Deir el-Zur, which is a northeastern area very close to Raqqa, where the Islamic State is in control, and where they have control in that district. And it is considered to be related to the fact, like the cholera, that the raw sewage is being pumped from these areas directly into the Euphrates River and the areas which provide the drinking and washing water to the other areas not under their control. So with cholera, polio represents a form of a spread of the disease related to the conflict, but possibly a bioterrorism aspect where they're kind of basically moving the raw sewage. What is even more alarming is the fact that the strain of poliomyelitis in Syria has been linked to a wild type from Pakistan, particularly from a jihadist fighter who came from Pakistan to the area, highlighting the regional spread of this disease and the potential, again, for a global spread. Measles is another problem. I've mentioned it in my written testimony in Aleppo and then spilling over to Lebanon, for example. In 2013, the number of cases of measles among Syrian refugees increased to 1,760 from a baseline of 9 cases the year before. The same is true among the Syrian refugees in Jordan. Dr. Hotez mentioned about the leishmaniasis, which is referred to also as a flesh-eating sort of a parasitic infection. 52,000 cases were reported in 2012 after a time when this was considered to be a contained local infection more in northern Syria. MERS remains to be alive and well. You're well aware of the outbreak, large outbreak in the summer of 2015 in Riyadh in Saudi Arabia, as Dr. Hotez pointed, but also the recent outbreak in 2015 in South Korea with transmission of the organisms, basically the index case traveling from the Arabian Peninsula. So again, highlighting the spread of these diseases. I would like also to highlight in North Africa, although the hepatitis C epidemic in Egypt is not directly related to the conflict, but has been put under the rag for a long time. A recent study by D. Miller with the Cornell group highlighted the fact that there is every year more than 500,000 new cases of hepatitis C, where almost 20% of the population, 15 to 20% of the population have this virus that has the potential in up to 85% of them to go into liver cirrhosis and hepatocellular carcinoma. So this is a major concern. The major concern in Egypt is that this is being propagated through the healthcare system, where almost 18% of the dental instruments have the hepatitis C RNA, 90% of patients on hemodialysis will end up with hepatitis C, and 70% of the blood transfusions that are being given are really not being checked for hepatitis C. So I came recently from a visit to Egypt. I met with the head of the National Committee for Control of Viral Hepatitis C, and I've been in contact with the CDC, basically, Dr. John Ward, who has been in contact with the CDC groups there. I met with the CDC and USAID, as well as the NAMRO group there, and there could be a lot of good effort that could be done in a concerted effort to contain and basically eliminate the spread of this virus. I also came from a trip from Mauritania. 10 days ago, I was in Mauritania, met with the President and the Minister of Health, as well as our ambassador, Mr. Larry Andre, and talked about the hepatitis B epidemic there, where almost 15% of the population have this problem. And we can, Ambassador Andre has advised us to, and we've been in touch with the CDC to really curtail that problem. I would finally like to highlight two major problems. One is multi-drug resistant TB, which is not much is being mentioned about, but we are detecting it from our groups. We're working in Mafraq, in Al-Noor Hospital, which is a TB sanatorium in northern Jordan, among Syrian refugees mainly. And this other problem is Salmonella typhi, typhoid fever, where an outbreak has been reported in the Yarmouk camp in a suburb of Damascus with resistant organisms. Home has been serving as a group there, and most of us are from Middle Eastern origin. We've been working widely in all of these areas, particularly with mobile, a big network of mobile medical units and field clinics that we have established in various countries. We work closely with Samaritan Purse, World Vision, the National Arab American Medical Association. We've worked with the American College of Chest Physicians and the American Lebanese Medical Association. But we believe that HOME and other groups, other NGOs working in the area, and this is what we would like to propose, should have work in a concerted effort, collaborative effort with governmental agencies such as USAID, CDC, and Peace Corps. And we ask that this subcommittee would, under you, Mr. Chairman, would call for a meeting for all relevant committee chairs, including the Health Subcommittee, with the experts, including Dr. Hotez and Dr. Morrison, and as to set a plan and a policy for this joint effort for the Middle East, and have a model similar to what we've done with Ebola in West Africa, where we have a concerted effort among the NGOs of Americans working there, as well as governmental agencies, to try to contain these infectious problems in the area. Because there is no doubt, like the Ebola, that they're going to spill over. And we're going to reap the consequences. In addition, it could be part, and we're talking here to this esteemed subcommittee, which is a subcommittee of the Foreign Affairs. This could be part of the medical diplomacy, if you may, initiative in combating terrorism in that area and its implications of these infectious outbreaks. A lot could be done in this concerted effort in terms of a refugee medicine training, in terms of early detection of these infectious diseases, working with the World Health Organization on community health and water decontamination, hygiene education, vaccination campaigns, and appropriate use of antimicrobial therapy, which is very important for TB and other, particularly training the local community physicians on how to appropriately use antimicrobial agents. Thank you very much.
Dr. Rad, thank you very much for your testimony and specific concrete proposals for follow-up. I'd like to now recognize Dr. Morrison.
Thank you very much, Representative Smith and Representative Barra. Appreciate your leadership on this and the opportunity to be here today. And special thanks to Greg Simpkins, an old friend, for his leadership in pulling things together today. I worked on this subcommittee in 1987 and 1991 when Dante Fascell, Henry Hyde were the iconic leaders. I worked for Howard Wolpe. Dan Burton was the minority member of that committee, and that committee had enormous impact in those years, and I'm very proud of that. That was the first job I had out of graduate school, and I believe very strongly in the power and impact that a subcommittee like this can have today, and thank you for your leadership and for putting a special focus on this subject. I'm going to make 5 points. My first has to do with, with health security and where this crisis in Syria and the Middle East sits. We've had a lot of discussion around Ebola, a lot today about Zika, a lot about the global health security agenda. We haven't situated this crisis too much that we're seeing in Syria in terms of health security, but I would argue that what we're seeing in Syria and the surrounding region is a very grave health security crisis that's gathering force. And it will become more evident. That health security crisis in Syria and the surrounding region is going to become more evident as infectious outbreaks proliferate and as other multiple health consequences become clearer due to the dissolution of the Syrian state, the deliberate targeting and destruction of health infrastructure, including killing of health workers, and the massive dislocation of vulnerable populations. We're going to see the indicators. Dr. Hotez, Dr. Rad both enumerated the evidence of this in terms of malnutrition, chronic disorders, maternal and newborn health, infectious diseases, and the scale is formidable. It's reached a point of, really, for Syrians, we're talking about 12 million, over half of the population. I realize addressing this has a special set of challenges, particularly on the security side. This is an acutely dangerous and forbidding environment. Access by humanitarian health workers has become exceedingly limited. We're operating largely in the blind in terms of data and access and surveillance. And we need to admit that, but I think the situation is changing in some important ways. So that's point one. Point two is we ignored this problem for a while. The war started in Syria in 2011 in March. I would argue that for the first 3 years we were pretty numb, disengaged, and paralyzed as a staggering and colossal human crisis unfolded in that period. The crisis was seen as too distant, too difficult, too dangerous. And that perception only worsened as more and more armed radical Islamist groups gained prominence, even before ISIS entered in June of 2014. And it became more difficult as MSF, as the International Committee of the Red Cross, as other NGOs were targeted, kidnapped, threatened, and harmed grievously in that period. There was an assumption that the surrounding region, the borderlands, Turkey, Lebanon, Jordan, would absorb these populations and that they would not move beyond that. That proved to be a very mistaken assumption. They took in 5 million, but they quickly reached a certain saturation point, which I'll say a bit about in a moment. In that first 3-year period, the geopolitics around this crisis was particularly toxic. The standoff between the United States and Western powers versus Russia, Assad, Iran. And the UN Security Council stepped forward and tried to address this but with a number of resolutions that were toothless and ineffectual and did little to, certainly in terms of Assad's behavior, in terms of the egregious and flagrant violation of international law in this period. We as a government were preoccupied with the Iran nuclear negotiations, and we were progressively seeking to lower our profile in this region. Options like safe zones, no-fly zones were explored, but ultimately rejected as too risky and too difficult. We did intervene in the destruction of the chemical weapon stocks in Syria together with the Russians, and that was relatively successful, but there was no humanitarian bounce that came off of that. Steadily, up until recently, the funding levels for humanitarian operations into the UN were cut dramatically, and that resulted, of course, in a humanitarian regression and undermining the status of those populations that were reached in the bordering states. My third point is that the situation geopolitically has changed fundamentally, and we ought to take account of that. And I'll explain what I mean. I think that the geopolitical change has in fact pushed health and health security to the forefront of the stage, and it's created some very early opportunities potentially. The tipping point came, of course, as Turkey, Lebanon, and Jordan reached their saturation point, as the monies coming in on humanitarian operations were reducing, and as the Syrian populations, both in those settings and inside Syria, made a dramatic calculation in 2015 to embark straight off for Europe. So the numbers of Syrians moving went from 100,000 in 14 to 500,000 in 2015, accounting for roughly half of the population. And those flows are continuing today. We're expecting fully a million more migrants this year into Europe, if not more, with a heavy share of those coming out of Syria. That, of course, has become a destabilizing factor. Just look at what's happening in Europe. Look at what's happening in Austria and the Balkan states, where there's basically they're freezing up the free flow of populations, refugee populations. Greece is becoming a black box, a holding operation. The politics are broken of the EU, and it's becoming an utterly untenable and destabilizing situation. The geopolitical situation changed in two other very important respects. ISIS entered the region in June of 2014, displaced 3.2 million people, took under its control roughly 8 to 10 million, and then, of course, you had the Russians enter in September of last year and begin the aerial campaigns from Syrian bases, which drove, up to now, have driven 300 to 400,000 people up to the Turkish borders and systematically targeted hospitals clinics and other facilities. So why is it now possible to think a little differently about the health crisis in Syria and the surrounding region? The context has changed. The U.S. is now working with others in aggressively trying to achieve a cessation of hostilities and expand humanitarian access to the besieged and those difficult to reach inside Syria. That's about 4.5 million people. Right now, the aim this week is to reach 150,000 in besieged cities and to continue on that trajectory to reach 1.7 million by the end of March. We don't know if that's possible. It's supposed to be done under joint U.S.-Russian oversight. We know this is a very perilous undertaking, but if it is successful, it will create new windows for restoring capacities, including basic services and immunizations. We're pressing at this same time to accelerate negotiations over a national transition in Syria and expand support dramatically to the frontline states, Turkey, Lebanon, and Jordan. February 4th was the astonishing summit in London, which took in pledges of $11 billion, $6 billion in 2016 alone, $1 billion from the United States. These are unprecedented levels, and it's a stark reminder of just how geopolitically important this crisis has become, that you could have something like this happen. Money is not the barrier. The barrier now is becoming access, vision, political leadership, and capacity. My fifth and final point is that there's more that the U.S. can do. The U.S. has been very generous on the humanitarian front. We've invested over $4.5 billion into the humanitarian response to this crisis since 2011. We're carrying 50% of the freight. But there's more that we can do. And let me just say a few specific things. We need to get U.S. public health experts closer to the problem on a long-term and continuous basis. Right now, in the cholera outbreak, we were channeling volunteers, we were channeling temporary employees into UNICEF and WHO. We should continue that. We should step that up. But in order to be really effective in this next period, we need a hub within the region, perhaps in Jordan, a continuous presence charged with coordination, quick response, and building relationships across the region. This is an essential step to enlarge the U.S. reach and influence and to be better positioned to get smart about what's going on inside Syria and to build the relations with the frontline states and address the health security threats we're talking about. There's much more that we can do to support Turkey, Lebanon, and Jordan. They have serious health security needs, but there is access and opportunity to do that. We have not framed this in terms of the global health security agenda. I'm arguing that we should think about that. We should think about planting this within that vision. That's a way to get assessments going. That's a way to leverage the G7. That's a way to offer an international framework around this. It has not been applied typically to situations as dangerous and complicated as this, but there's no reason why it could not be. Lastly, the U.S. is not in a hegemonic position to drive events. We are in a position to be very influential, but we're not going to be the hegemon as this health security crisis grows. Russia has established itself as a major driver. It's been a major contributor to chaos, dislocation, and suffering. It's weaponized refugees, but it appears that there is some changes going on, and we are going to have to move forward aggressively to rebuild capacities with the Russians, the Saudis, the Turks, the Iranians. We're going to have to rely very much upon our friends at the International Committee of the Red Cross, MSF, Doctors Without Borders, Syrian Red Crescents, courageous groups like the Syrian American Medical Society, which has done remarkable work. So thank you very much, Mr. Chairman, for your patience.
Dr. Morrison, thank you for your insights, your leadership all these years, and I'm sure you missed being here on this side of the dais. I do have a couple of questions, and I'll probably come up with a few more that we might submit in writing, but to begin with, Dr. Hotez, how many vaccines do you have under study at the Sabin Institute?
Thank you for that question. We have six vaccines now. So for hookworm, schistosomiasis, leishmaniasis, Chagas disease, SARS, and MERS.
And are any of those ready for for deployment?
Well, right now, they're in various stages of product and clinical testing. So we have 2 vaccines in clinical trials in Africa and in Brazil for hookworm and schistosomiasis. The SARS vaccine is about to be manufactured, and the other ones that are earlier stage. You know, one of the big problems that we face, of course, is funding. So there's not a real push mechanism of funds that go to product development partnerships. These nonprofits fall through the cracks. They use industry practices, but because they're not registered as small businesses or businesses, we don't benefit from the SBIR mechanism, for instance. And whereas the Dutch government, the German government has now specifically started funding PDPs specifically through and Japanese as well. It's not really done in the United States. So it's a gap that we could be addressed through the Center of Excellence concept of the neglected disease legislation, but we need more mechanisms like that.
Now, with leishmaniasis, you mentioned that there's a need for a vaccine.
Absolutely. And there's proof of concept that it's quite possible.
Okay.
Because what the locals do, it's quite interesting. They will scrape the lesions of somebody who has leishmaniasis and inject it into the buttocks of their kids to prevent them from getting a disfiguring scar on the face. It actually was discovered by the ancients. It predates vaccination. It's called leishmanization. But it shows you that you can make a vaccine. Now, we can do better than doing that. And we can do it by genetic engineering, making a recombinant vaccine. And we've done it now in the laboratory. Now it's a matter of getting support to scale it up.
What would it take to scale it up? I mean, what kind of money are we talking about?
Well, we're looking at around $5 million to really move it into clinical trials. And that's the incredible thing about this. It's, you know, it's not billions, it's not hundreds of millions, it's not even tens of millions. It's 10 to the $6, not 10 to the 7th or 10 to the 8th or 10 to the 9th. So the funding needs are so modest, and yet it's just not there.
One of the reasons why I've introduced the Neglected Tropical Diseases Act, because it really does take a modest amount of money to have a spectacular impact. I would note parenthetically that for the second year in a row, the administration's budget has looked to cut the neglected tropical disease budget, and thankfully, in a bipartisan way, we've been able to get the appropriations at least at level funding at $100 million, but it was a 20% cut now 3 years in a row, that too, which is very disconcerting from my point of view in terms of prioritization.
And especially since the U.S. government's getting so much bang for its buck. Through that $100 million a year, you're eliminating 3 diseases. I mean, where else in the U.S. government can you get that kind of impact?
Exactly. Let me just ask you, Dr. Rad, on Mosquito-borne. You talk about how it's spreading, 36% mortality rate. You know, we're all, I think, thinking, you know, after World War I, the misnamed Spanish flu, obviously the incubator for that had to have been the degradation caused by World War I. Is this one of those possible diseases, illnesses that could spread and become a pandemic? We know it's local and it's causing a huge amount of sickness and death. But looking at all of these diseases, including that one, what's your thoughts on that?
Yeah, I mean, the South Korean outbreak is the best example of the global spread of MERS. And we've seen MERS cases not only in the region, but beyond the region. So, and it's a coronavirus. As you well know, SARS is a coronavirus and had a global spread. So there is always that concern that it could have a global spread. Again, the good work of my colleague, Dr. Hotez, as far as vaccination would be very important because at this point, all what you provide for MERS is supportive care. And this is why the relatively high mortality rate associated with it. But also early diagnosis and to be on the alert. And I think MERS is part of the bigger picture of the Middle East. The Middle East needs a special attention as far as infectious diseases. And this can be done, and it could be done as part of this concerted effort, but also could be part of as I'm talking here to your subcommittee, which is part of a committee of foreign affairs, part of the medical diplomacy to reach that area. because the uniqueness of the United States is that we're not just providing a activity on the ground like the Russians are doing, and as Dr. Morrison has mentioned, in terms of a force, but providing also a solution to some of the devastating problems, including these epidemics, and solution to the refugees. So I think there needs to be a concerted effort with a special attention between NGOs, governmental agencies, groups working like my two colleagues here to reach out to the...
And I do thank you for your idea of bringing the other relevant chairman and subcommittee chairman together. I think that's an excellent idea that we will look to follow up.
Thank you.
I want to ask you with regards to the bioterrorism you spoke about, that chlorinization had discontinued.
Yes.
Is that one of the casualties of war, or why did that happen?
Well, it's one of the casualties of war. The whole healthcare system, if you may, and the sanitary system has collapsed. Syria, as you well know, is the basic needs, basically, of the people are non-existent. And I would dare say, from reports of our colleagues in Baghdad, the same is true is happening within Iraq. Baghdad is in chaos. And I had some of the slides that I sent where people are going to wells that are already contaminated to provide the drinking and sanitary water.
Dr. Morrison, you note that 500,000 children under 5 in Syria have not been vaccinated in more than 2 years. Is there a danger of unrestrained polio? Is that imminent in your view?
There's a risk. There's a continuous risk of further outbreaks of polio. There were 35 cases of polio in 2013. There was one case in January 14. There were concerted efforts undertaken by a consortium of groups under the Global Polio Eradication Initiative that have resulted in 12 campaigns, 12 immunization campaigns that have been undertaken. And that's a remarkable achievement given the gravity of the situation and the dangers involved, and the intensification of the war itself. The fact that polio has been contained through those efforts, however, doesn't leave me completely confident that we're not going to see more outbreaks, more cases as this conflict continues. And I think there has to be, and there is, pretty concerted vigilance across the region. No state within the region wants to see the reintroduction of polio into its borders. I mean, when that first case happened in 2013, there had not been a case of polio in Syria in 14 years before that. And this was a country that had managed its campaigns very competently, very effectively across a range of immunizations. And but that's broken now, and we know the hazards. So I would say a need for continued high vigilance, but also you know, an awareness of the achievements we've seen in the last period in reacting to those 2013 outbreaks.
Dr. Hotez, you mentioned that the Hajj has had an impact on the spread of the Zika virus, or dengue, I should say, and you raised concerns about the Zika virus potentially being spread that way. Do the clerics, do the leaders of Saudi Arabia understand the potential pitfalls, and is there a plan of action that could be used to mitigate that?
Yes to the first part, but I think they're a bit mystified about where to go from there in terms of restricting, because one of the problems that you have with Zika is that many times you're without any symptoms at all. So you're going to have people coming in carrying the virus in their bloodstream without showing any manifestation. So it's not like you could check them at the Jeddah airport and say, don't come into the country. So this is going to create going to be a real problem. We're going to see this, and the Hajj, I think, is occurring late in the summer, early fall this year, and that's going to be a huge issue.
I mentioned earlier the targeting of so many medical personnel. Well, now that there's a cessation of hostilities, of course, it doesn't apply to ISIS or to al-Nusra. But my question would be, are the medical doctors, the healthcare workers streaming in during this, you know, this lull in hostilities, knowing that there are grave risks to them and that these hostilities could recommence at any moment?
Yes, I think in addition, I mean, all of this has escalated to tremendous number of healthcare workers, particularly physicians, immigrating and leaving the country with the exodus and left basically so the best policy is to work with the local people, and as long as we're working with groups that are neutral, non-discriminatory, and doing the work on the ground, and to strengthen. And I think there's something similar to the healthcare, or if you may, the health strengthening bill that is there for Africa. Something similar should be done for the Middle East, and to work with local groups on the ground in order to retain them. Because the healthcare workers are like anyone else, basically, in the midst of the catastrophe, and particularly when they are targeted. We had difficulty having a mobile medical unit in Syria because it would be either shelled or basically, and the people would be killed, and then the mobile medical unit would be taken over to be used to kind of transport weapons and so on. So I think the most important thing is to work within the system collectively and try to strengthen the healthcare system.
I don't think you're going to see a sudden return. Well over half of the 30,000 doctors that were in Syria prior to the advent of the war in March of 11 are gone, and they're not coming back. And you've had over 800 healthcare workers murdered in this period. You've had the deliberate targeting. Your infrastructure, fully half of your infrastructure is either destroyed or non-functioning at this moment in time. So I think and the security threats remain very grave and very fluid. So I think what you're going to see is a step-by-step incremental reintroduction of personnel with heavy security guarantees around this. The UN convoys that have been going in this last few days into the 5 or 6 besieged cities, some in the government territory, some in opposition controlled. These are trying to get to those 15 sites where you've got 450,000 people who've been cut off for months and months and months. Those are being done with very heavy preparations, very heavy concerns around security. I might add one other thing. You have you have the city out in the east that's besieged by ISIS, where you've got 200,000 people. There, airlifts are being attempted to reach that population. They're having serious problems with those, and of course, airlifts are terribly expensive and not particularly effective oftentimes. But that's another measure of how desperate that population is. But to get Syrians back in and to get international health personnel to go back in, you're going to have to lay a pathway down in which their security is going to be guaranteed and protected. And this is a much bigger challenge, even than trying to get the hundreds of health workers who were needed to go into the 3 Ebola states in 2014, who were terribly worried about evacuations should they become infected or at risk, or if they perhaps infected. So we face big challenges. There's a lot of very courageous people in civil groups that have stayed behind in ad hoc facilities, who are who are doing cross-border operations, who are working from the side of Damascus. The Red Crescent has lost hundreds of people in this period. There are many courageous people who have stayed to try and keep the lights on, and they deserve a great deal of credit.
Agree with all these points. I'd like to make the additional point that Ebola was relatively easy to contain because it was contained in a relatively isolated area of West Africa. Look where the Middle East is. It's at the crossroads of Asia, Europe, and Africa. We're already seeing the expansion into southern Europe. Dubai is one of the busiest airports. We're going to be seeing widespread dissemination across into Pakistan and India, and then into sub-Saharan Africa. So in terms of priorities in the global health security agenda, I think the Middle East has to be one of the most important, because we're going to see this continuous seeding of 3 continents with infectious diseases, and we're already seeing the beginnings of that.
Thank you, Chairman. You've laid out a number of challenges that we obviously face, and if we were to start to look at these as separate challenges but interrelated challenges, one challenge is in the refugee camps, whether you're looking at Jordan, Lebanon, Turkey, and how we approach those challenges where safety may be less of the risk, but the conditions under which people are living clearly is a risk, and an incubator of sorts where if you do have an outbreak, things could travel fast. So I'd segregate that and think about how we address some of that challenge. Looking internally in Syria or occupied areas within Iraq, safety becomes an issue. The infrastructure, Dr. Morrison, you pointed out some of the infrastructure that's been decimated certainly becomes an issue, and that how you get healthcare personnel in there may not be as feasible, but how you work with the individuals that are still there and the infrastructure there may be a different challenge, and how you address that. And then we've been talking a little bit about MERS and so forth, and again, in folks that may be traveling to the Hajj and then traveling back to their home countries, how you work, whether it's MERS, whether it's or dengue or Zika virus, how we work with the infrastructure in Saudi Arabia in a country like that. So folks that are coming there may perhaps getting exposed and then returning to all parts of the world, how we work in that. So I'd think about it in three separate ways where you may have slightly different solutions, and maybe Dr. Morrison, if you want to start.
Thank you, Dr. Barra. I think those are great points. A few thoughts on that. One is to keep in mind the demographic transformation that's going on within the region. Syria before the war was 23 million people. Syria today is roughly 17 million, and it's continuing to empty. I do not believe, given how devastated this country is and how you've seen the dissolution of unitary sovereign power, I do not expect you're going to see many of those who have fled coming back anytime soon, and there has been a shift of thinking today towards those populations in Turkey, Lebanon, Jordan, working towards enabling those countries to be able to provide employment opportunities, education, housing, health services, and the like to those populations as well as their own citizens, and restabilize those societies, and make it in their interest to take that step. And you've got trade deals, you've got the EU stepping forward, this London conference I spoke to. That is a big shift of thinking and a very important one. On the access internal to within Syria itself, I think we need to come at it from multiple directions. The WHO, UNICEF have shown extraordinary courage in their operations, though they will remain central in trying to use their legitimacy and their record and their access to move forward. But there's going to be more and more cross-border work. That has been validated and endorsed unanimously in the UN Security Council resolutions, and that those corridors can be opened up as well. Thank you.
Dr. Rad.
Mr. Berra, I think you bring a very very insightful thought into this, because this is a very complicated problem with multiple dimensions and sort of moving variables. And you pointed to the fact there needs to be a strategy for the refugees and the displaced country, who are displaced in these countries like Jordan, Lebanon, Turkey, versus something else respected to the areas that are inside the war zone, if you may, Syria proper, Iraq. There are certain areas where we cannot get to, like we're under the control of the Islamic State, so this is this is kind of a red area where we're going to get to. And then there needs to be a contemplation or part of the policy of the Hajj and the flux and the movement that is taking place and how to handle this. So I think this is why we need a team that would be looking into all of this, because now a lot of groups are working from the U.S. and sometimes the right hand is not knowing what the left hand is doing. And there is excellent effort Dr. Morrison has pointed out, and great ideas but Dr. Hotez has brought into the picture. But we need to integrate this into a one common strategy where in these different areas, how do we act and how do we work? This is why the thought in some of these areas, we have to rely on some of either the local people or more Arab Americans that are willing to work there. Dr. Morrison mentioned SAMS. The Arab American Medical Association, we are Arab American that are work from various backgrounds and faith values, as long as they remain neutral and within representing, they are the sort of the medical diplomatic Peace Corps, if you may, of this country that are moving into this area. But it should be part of a bigger picture of a general policy that is being devised by your committee and other relevant committees.
Right, Dr. Hotez.
I would just mention also the other actor in this could be the Russians in doing some cooperative medical diplomacy activities with with Russia. There's precedent for that. Many people don't realize that the oral polio vaccine most of us took as kids was developed jointly between the U.S. and Soviets at the height of the Cold War, right after the Sputnik launch. Two countries put aside their ideologies and made the polio vaccine, and they cooperated to make the dry vax for smallpox eradication. So there's precedent for that, and it would be an interesting opportunity to investigate.
Great, thanks, Dr. Hotez. Dr. Morrison, how are medical personnel, and actually any of three witnesses, medical personnel that are not attached to, that are going into this war zone, how are they perceived by, whether it's the Assad regime, whether it's some of the rebel fighters outside of the Islamic State? Are they perceived as neutral players coming in for humanitarian need, or are they under constant threat as well?
In the chairman's opening statement, he referenced the study by the Physicians for Human Rights. That group, as well as the International Committee of the Red Cross and Doctors Without Border, MSF, have carefully documented and tracked what's happened in Syria, which is harrowing, which is the deliberate targeting of health personnel and infrastructure. The most egregious violence coming from the Assad government, and most recently from the Russians. But not limited to that. And you have the introduction of radical Islamist dimensions into this as well, where it becomes actions taken against Westerners who are seen as carrying a hostile agenda, and they just happen to be operating in the health sector. So the respective neutrality of these operations has eroded, and the degree to which the providers themselves have had their access to populations and their abilities to function have narrowed significantly. They don't have the benefit that in other conflicts where you've had a legitimacy and a respect and level of protection, where even in a highly conflicted setting, you could migrate across lines. Instead, you're seen as partisan, as party to one side or another, giving active support, and in fact serving those who are wounded, who are combatants, as simply implicating you. So leaving you open to being attacked because it's just part of a broader combat operation.
Okay. Shifting gears, Dr. Hotez, you talked about what it would take for vaccine development. And let's take leishmaniasis. If we were to be able to appropriate the funds to do the research and come up with some of these cures or viable vaccinations, in your assessment, kind of looking at American pharmaceutical companies or global pharmaceutical companies, because you'll now have to commercialize some of this, is there a market for commercialization, or would it, in many ways, would we have to continue to appropriate those funds or through that WHO or other organizations?
I think, thanks for that question. I think once the product's developed, there is a commercial market and there is a commercialization plan. It's modest. It's, it's a fraction of what some of the other vaccines are that Merck and GlaxoSmithKline makes. And even the vaccines are less than a lot of the small molecule drugs that we all take. So it's a very modest market, but it's not zero, and it should be sustainable.
Okay, great.
But
actually, I'll
May
go.
I just add one
Yeah,
point?
please.
Dr. Berra, in this last year, there's been 4 major studies of what happened in Ebola, undertaken by the Stocking Panel, the Harvard-London School Panel, the National Academies of Medicine, the UN Secretary General's high-level panel. All 4 of those panels, to varying degrees, identified the R&D dimension as a critical gap, one where there needs to be a mobilization of resources and a higher level of effort in order to create some kind of platforms that would prioritize those dangerous and neglected diseases for which there's no market, and be able to get the early development accelerated through new initiatives. And at the Davos, at the World Economic Forum earlier this year, a number of players came together to try and build on that momentum coming out of Ebola in those 4 studies and move it to the next stage. And that's led by the Norwegians, with the Wellcome Trust, Gates Foundation, the British government, and others. And that's moving along. And I'm hopeful. Peter probably knows more about exactly what might be in store on this, but it's still getting worked out. But at some point later in the year, I think Ebola convinced us of the need for a higher level of action to correct for this and to put us on a different pathway.
Before I yield back, let me thank the chairman for his leadership in making sure we don't forget about some of these neglected diseases that pop up, and making sure that we continue to focus in on this. If we use the Ebola example, we're not that far off from developing a vaccine and developing, is that a correct statement? That with a concerted effort we could come up with?
specifically for Ebola now, after there was a big investment by the U.S. government to get it launched, yeah, I think we're pretty close.
So we're pretty close. If we were to now look back in hindsight and think about how much we spent cumulatively globally to maintain, contain, and treat this last outbreak, I'm going to guess it's not an insignificant amount of dollars that went into that. Is that?
Well, I'm sure Steve knows those numbers probably better than anyone, but the economic impact of Ebola was certainly in the billions of dollars. I'm sure there's a specific number attached to that. You can imagine what the economic impact of Zika is going to be on the Caribbean economy, for instance. And we're going to see this again now with the diseases coming out of the Middle East. It's already in Southern Europe. What's going to be the impact now of having malaria in Greece? So there's no question these innovations will pay for themselves hundreds of times over.
Dr. Morrison, do you have an idea of what that number is?
In terms of the economic cost for West Africa of Ebola?
Yeah.
The World Bank has tracked that cost fairly carefully and also offered projections. In the first phase of 2014-15, it was somewhere in the order of $3 to $4 billion, if I recall, which may not sound that much, but when you're talking about economies of this scale, I mean, these 3 countries have a total population of 22 million people. They're among the poorest countries in the world. That's a pretty serious setback. And just to add to this, I mean, just OECD just 2 days ago came in with estimates of what was going to happen in Brazil, and we're looking at a 4% drop of GDP in Brazil this year. Now, before Zika hit, they were having trouble. But this can have profound impacts on an economy as big as Brazil's.
Right. And it's fair to say we will have another Ebola outbreak, whether it's this year whether it's 2 years from now. So it is a drop in the bucket to not stop now, but actually continue and finish it and come up with that vaccine and that therapy.
Yeah, as we pointed out, I mean, to launch a leishmaniasis vaccine or a MERS coronavirus vaccine, it's a few million, and the economic impact's in the billions. So anybody would tell you, any economist would tell you it's a great investment. It's just a matter of getting those initial funds mobilized.
Let's go ahead and do that then, so we don't have to, lose those billions on the back end. Thank you, and I'll yield back.
Thank you. Before yielding to Mr. Clausen, who just appreciate you being here, the two questions. One, as we all know, incentives make the world go around. You point out, Dr. Hotez, that there's no commercial incentives to develop new tools, and you do point out in your testimony, unlike the EU and governments of Japan and several European countries, the United States government does not specifically fund initiatives that support product development partnerships, or PDPs. And you mentioned that there are 16 to 20 PDPs globally. I wonder if you could tell us how many are in the United States. What do these other countries do? Are they tax incentives? Are they grants? Are there a number of best practices that we ought to just look to apply to our own situation here in the United States? Again, learning from the EU on this one, and Japan.
So thanks. So of the 16 to 20 PDPs, they're kind of equally shared between Europe and the United States. So about half in the United States, half in Europe. But the way that things are working on the European side is they're being mobilized through their Ministry of Foreign Affairs. So the Dutch government has launched a fund for product development partnerships. So has the German government just released one. The Japanese government has just released one. And the way they operate is through what are called RFAs, requests for applications. They're really they're lifelines for us, because the Gates Foundation has dramatically decreased funding for PDP. So Gates Foundation funding for product development partnerships is about half of what it was back in 2008. So some of them are really struggling now for survival, and we're going to lose all of that innovation expertise. So it's great that the European governments have done this. What I've said is, the U.S. government doesn't have an easy mechanism for funding PDPs right now. They do fund one specific one, IAVI, which is the International AIDS Vaccine Initiative. They're a very specific appropriation that goes through USAID. It's a pass-through, but beyond that, they don't really. And even if you mobilized 1% to 2% of funds for global health for PDPs, that would release $100 to $200 million into the system. That would do it, or right then and there would do it.
Why has Gates pulled out, or at least diminished their exposure?
I don't know. This current regime is very focused more on supporting directly industry, it seems, and so they're taking some different routes, but we'll see how long that lasts for. But and they're still funding us, fairly well, but not as much as we used to. But as I said, for some of these vaccines, 5 million here, 6 million here, 3 million here. It makes a huge difference. We're doing our whole Chagas vaccine project on $4 million. We were able to get a schistosomiasis vaccine from discovery through clinical trials all the way for $2 million. And that was done in part because NIAID rescued us, and they paid for the clinical trials separately, and they paid for the toxicology testing.
When might something for leishmaniasis be available?
Well, we could go into manufacturing pretty soon, but we don't have the funds right now. So we could probably go into manufacturing by next year, or if not earlier. But
could we get all the details on that?
Sure.
From you?
Yeah, absolutely.
Appreciate that. And one last question. On the G20 question, if we as a subcommittee put together a letter, which I think would be a great idea, I would appreciate if all three of you would provide us insight as to what you think ought to be in that letter.
Absolutely.
Thank you.
Fantastic.
Yes, Dr. Rad.
Mr. Chairman, I think the issue of vaccines is extremely important, but from my interaction in the area, there is a tremendous respectability to to the healthcare, the U.S. healthcare system, and I think we can do a lot with whatever we have as we're developing new vaccines. For example, the polio there is an available vaccine, but how to implement it there, the issue of water sanitation, the refugee medicine kind of training, the early detection of these diseases. I think we have the best healthcare system in the world, and they look up to us. And again, to improve relationship maybe beyond governments with the people, if they would see us as a country trying to reach out with in a way to provide them better health and an opportunity to kind of deal with the catastrophic situation, I think a lot can be done. Appropriate use of antimicrobials and training programs for the people who are doing relief and so forth.
You know, I saw in your list, you mentioned training other healthcare personnel for refugee situations. What does that take, a weekend, longer?
I mean, it might take a week or 2 weeks on refugee medicine and how to deal with different situations. There is tremendous need for such initiatives. And on the ground, they are effective. And
who are the trainers?
They're cost effective. I mean, you can send trainers to train them in areas that are safe, like Jordan or possibly Lebanon, or maybe other places. But you can, they're very cost effective. I mean, the whole thing is not a...
Is USAID doing that now?
I'm not sure. I mean, I would like to investigate. I've been in touch with them. But this is something that could be emphasized.
Mr. Clausen.
Sorry, I came late. I had another meeting. We were often double booked up here, so appreciate y'all hanging around long enough to hear my questions. I may very well be repetitive since I haven't heard what's already been asked. So if that's the case, I apologize. And when I think about mosquito-based illnesses, I have kind of this sequence in my mind that starts with, at least with daytime diseases, mosquito-based diseases. It starts with dengue fever, times 4 strains, then chikungunya, now Zika. And each one of those rides the same Trojan horse, the same tiger mosquito, and that there will therefore be another Zika or another chikungunya, or that the movie we've been seeing the last 10 years or so will continue, and the next one could be even worse than Zika and could be, a real disaster. That's how I think of it in my mind. And so although I like getting rid of stored water or, pool-in water, I like making sure people have air conditioning so they, kill the larvae under the bed, like all those things. It still seems to me that until we get something that takes out the tiger, the Aedes mosquito, that we're going to see this movie again and again and again. And so, I don't know if that's a genetic fix for this mosquito or but right now it just seems like we're going after the results as opposed to the base carrier of these types of diseases. Do you all see it the same way I do? And if that's the case, my theory would say the only long-term solution, at least for this strain, is to get on that mosquito. Y'all agree with what I'm saying?
Well, I guess I could start. This morning I testified to Energy and Commerce we held hearings about Zika, and I work on the Gulf Coast of Texas, and I focused on the fact that the Gulf Coast of the U.S., Texas, Louisiana, Mississippi, Alabama, and Florida have something very unique. We have not the Asian tiger mosquito, which we have that as well, but the real bad actor is Aedes aegypti, which is the one that's transmitting Zika into throughout South America, now into the Caribbean. The other factor that the Gulf Coast, our states have, is poverty, and that's not often appreciated as a risk factor. But the reason why Zika is wiping out Pernambuco state in Brazil, and now it's going to decimate Haiti, is because women who live in poverty have no access, who live in houses without window screens or holes in the window screens, and the environmental degradation route breeds the Aedes aegypti mosquito. So I'm very worried about the Gulf Coast of the United States, more than many others. And the consequence of that is we need to do something about the mosquito. We're not going to have a Zika vaccine in time for this epidemic. And so I've been pushing very hard for a program, aggressive mosquito.
Just to interrupt, and we're not going to get rid of all pooling water in lower socioeconomic neighborhoods that don't have AC either. I mean, we need to work on all that. But we're to say that I'm in Southwest Florida, I'm on the Gulf too.
Yeah.
So I'm really worried about my more humble neighborhoods and their ability to fight back if the virus, if this mosquito comes north, and I'm not sure why it's not there now, but it doesn't seem to be.
It will come north, and so I'm quite worried we're going to start seeing Zika on the Gulf Coast, including your district, starting this spring and summer. And so the approach needs to be, one, we know we can go pretty far with old-fashioned methods using existing insecticides and getting rid of the garbage, getting rid of the discarded tires on the side of the road and doing what you can with water. There's some new technologies out there. Whether or not they're going to be available, whether they can be shown to be scalable in time for this epidemic is unclear.
Are we close on this mosquito? I mean, I got you that we need to get rid of tires and other pooling water and have more AC and more screen doors. We hear, but
That's
that,
right.
but,
And
but,
the other
but until we take out this particular mosquito, you know, not only in our country, but particularly, you go to the Caribbean and you go to Haiti or Dominican Republic or Curacao. I don't know. I mean, you know, no one has AC, and when it rains, there's water everywhere.
That's right.
Dr. Morrison, what were you going to say?
I support what Peter has to say, which is that control of mosquitoes is really hard, and it's expensive and it's tedious, and the old methods are still the ones that we're going to rely on in this period. And I worry enormously about what's going to happen in the areas where Aedes aegypti is endemic in the United States. And as it gets warmer, those areas are going to become enlarged. There are technological fixes that people are exploring. There's radiation. There's introduction of bacteria. There's genetic engineering. Those are three methods that are actively being explored. I think they are going to get much higher attention in this next period, but there are no quick fixes here.
I dropped, our office dropped the bill that would give a 10% tax credit, kind of like the investment tax credit from years ago, to any company that's working on what you just said. Because I'm with you, we've got to treat pooling water, but we've also got to get at this mosquito. And that's not the typical spraying methods at night that we would use for a malaria mosquito, right? This is a daytime, indoor, hot zone kind of critter, right? Let me ask one other thing, maybe.
Let me just say one of the other issues, problems that we're seeing in the U.S. is mosquito control is very much done at the local level, at the county or city level, and there's a lot of inconsistency in terms of how well that's carried out from county to county.
I agree.
So there's going to be, I think there's going to be some need for federal government intervention, at least harmonize technologies and come up with a more consistent.
Or standardize what the treatment ought to be, even if it's implemented locally. I think my districts are pretty good. My counties are pretty good, but lots of times when I travel, I see people spraying at night, and I say, that's going to kill the wrong mosquito. Right. And so we think we see a spraying at nighttime, that might be a good thing. As far as I can tell from this bug, that doesn't do anything. One more question real quick about the Middle East. I mean, it seems to me that you have distrust of governments, distrust of outsiders in the Middle East in general, can't get doctors in, bad water, bad sanitation. It's just an invitation for mosquito-based infectious diseases and all infectious diseases. And I don't even know where to start in that environment. By the way, I'm not sure it's American. I mean, I think in Southeast Asia and Africa, there's a lot of people that looked at other refugee crises and had to set up sanitation real quick you know, in previous wars. So I'm not sure it even has to be America, but I see that big, wide problem, and unless resources, even if it's regional, unless we can come in, it's going to be hard to solve it. Am I right on that, Dr.?
So, I fully agree with you. I think it's, as we mentioned earlier, it's
Sorry,
a complicated problem with it's multifaceted, and it's not one size fits all. I mean, you need to kind of handle it in different areas in different ways. For example, there needs to be a policy for how you deal with the refugees and the problems related to that. How do you deal within the areas which are the combat zone or maybe difficult to enter to? Where are has been one other issue is the issue of the Hajj, and where you have the aggregation of people, whether it's in Saudi Arabia or possibly Iraq in some of the places, and so forth. Water sanitation and the implication of what's happening now of the sewage being directed into the water supply for these areas from the areas where the Islamic State is. So it's a complicated problem, but I think it needs to be dealt with systemically in a multifaceted manner, creatively. I think there needs to be some creativity, because in some areas, but I believe that what you're saying is very true, but the response should be insightful, should be practical, and should be creative. And I think a lot could be done. The other factor is one has to account for the fact that the problem is escalating, there is so many variables that are moving targets occurring, but this is why there needs to be a special attention through a concerted effort and maybe a joint project between NGOs.
In some conflicts, more people die of illnesses than they do from gunshots or bombs.
That's very true.
What about in this case?
Which is true. For example, look at I gave some figures. An area which is not really in a major conflict, Egypt, where the conflict is mainly in Sinai, but people are dying. There are more casualties from hepatitis C in Egypt over the last 5 years than there are from the war in Syria. There's actually, 250,000 in Syria killed during the war. There's certainly all these outbreaks have resulted in a lot of people killed because of these infectious outbreaks, because of the Syrian-Iraqi conflict, if you may. So I fully agree with you.
Dr. Morrison?
There's been various efforts made in these current wars and in past to try and estimate mortality from various sources, and the data remains weak oftentimes, but there seems to be across multiple cases a sort of pattern where a substantial portion of mortality comes through the decay of your health system.
Okay, so let me interrupt 1
Vulnerability.
second. Can I have 1 more minute on this? What do we spend on bombs and guns and killing versus what do we spend on preventing disease?
That's a big question.
I know I know you thought of this now. Come on now. I know you all have thought of this, right? We spend a lot more on bombs.
I think that,
I'm just asking.
I think this is the whole point that we together were trying to bring, that a lot could be done if we appropriately use these resources in a targeted manner, and that would reflect a certain view in the region, particularly among the people. It's people to people of how they view the United States of America. That we're not involved in the conflict through the war sort of policy that we have, which is legit, and certainly we're fighting terrorists. But there is another side, initiative of this great country, where we're the kind of host of groups like Physicians Without Borders and so forth, that we're making initiatives on the ground, and we're having people move on the ground. And this had a tremendous impact in West Africa with the Ebola virus, and could have a tremendous impact on the people, and ultimately the governments in the area. If we have a good policy that would deal with this crisis, and we will become as the people who are trying to solve a major catastrophic problem.
You would agree in the case, I mean, I have a close friend who's a physician that went to Africa to fight the Ebola outbreak, as an example, university professor, physician, et cetera. I mean, a lot of Americans are great that way, right? If there's a problem around the world, we're always one of the few that swashbuckle and get on over there to help out, right? Sure. But it's a lot harder in war zones, and it's a lot of our dollars that are going in there to, right, to defend and make war. So maybe in those zones we ought to think, how can we also offset part of that with medical.
That's true.
And sanitary.
Congressman, we were talking earlier about the response to the human crisis that's grown out of the Syria war and has spilled into the region and now spilled into Europe. The United States engagement on that side has amounted to $4.5 billion since the Syrian war started in March of 11. The military side of the equation has been largely within that region. We've been scaling down our military engagement, but only recently scaling up with the coalition campaign against ISIS, right? That's the central investment that we're making within that region on a military grounds. So, I mean,
Which the president's original ask was $5 or $6 billion, something like that, correct? To train Syrian insurgents, as I recall.
I don't remember the exact number that was made in terms of the training. Can I come back to one point that you raised about the Zika response? Just to get back to that, because I want to, before we run out of time, I wanted to make one important point.
You know, the chairman over here might have a different view on that, but go ahead. You all right here? All right.
You know, it's going to be very important in this period that the CDC be able to bring forward additional capacities and resources to states and communities that are attempting to address these threats through a variety of different measures of sanitation, water, screening, AC, but and the current $1.9 billion request, emergency request that's up here for consideration includes, I think it's almost $900 million to meet that need.
Seems low. I mean, if I wanted to do an economic impact of an outbreak in South Florida, I could probably get to that number just in Florida pretty quick. Am I right? You all agree with that? So it seems low. See, 1.9 just seems low. Off just a cursory view of it seems low.
Well, I think you have to remember the consequences. If we start seeing clusters of microcephaly cases appear on the Gulf Coast by the end of this year, it's going to be spoken about in the same context as Katrina, Hurricane Katrina, or the BP oil spill.
Seems low.
So
The human cost would be, you know, hard to describe, right?
And when you look at the costs, I think it's important to keep in mind, you know, we're not talking about a crisis of Zika and of the mosquitoes. We're talking about a crisis of microcephaly.
No, I understand that.
Right?
I got you.
And the population that is most vulnerable is the pregnant women or women who are to become pregnant.
Right, in poor neighborhoods.
In poor neighborhoods in particular.
Where there's no AC.
And so we need to keep our eye on the ball in terms of what the most vulnerable population in need is.
And what was the basis for the 1.9? What's the?
Well, that's been detailed in the request that breaks it into its different component parts. They were making an estimate of the requirements in this first phase to get moving, and I think the urgency around this is what Peter's referring to, which is we do not know if we're going to see 8, 9, 10 months out or beyond, if we're going to see a proliferation of microcephaly.
You all would agree, and this is then, Linda, you all agree with me, even if it's not, remember where I started, even if it's not Zika, it's going to be something riding the back of this particular mosquito. So whatever money that we spend, even if Zika is not an outbreak, we might be very likely preventing a future outbreak in whatever we do to attack Zika now, even if Zika isn't our worst case scenario, there will be another one on the tiger mosquito that's going to get us.
You know, this Aedes aegypti mosquito that's endemic in these coastal areas, 23 million people live in those areas. This same mosquito carries dengue.
And chikungunya, yeah.
And you have had outbreaks that have been brought under control.
That's my point.
I mean, there was an outbreak in Key West of dengue in 09-10 that was brought under control. So it stands to reason that many of the same measures that have protected Americans against dengue and chikungunya, correct me, Peter, if I'm wrong, should be applicable in this instance with lots of modifications around the threat.
Right, which is why I'd like more than 1.9. It just seems like cheap money for future lives and problems. And with that, and I really like the CDC, by the way. With that, I yield back. Thanks for the added time. Appreciate y'all. Sorry I came in late. Appreciate y'all's input here.
Thank you.
Thank you, Mr. Clausen, and thank you. Anything you'd like to say before we conclude the hearing?
Just thank you.
Oh, okay.
all
But I mean,
for the
anything on the
opportunity to be
substance.
here.
Well, thank you for raising this issue because this has been below everybody's radar screen, and yet it's so important.
Thank you for the insights and counsel, and we do have a lot of things to do in follow-up. The hearing's adjourned.
Thank you, Mr. Chairman. Really good job.